Good morning. Welcome to In the Trenches with David Cohen. Today's topic is going to be endocarditis. That's at the request from my house staff and students. This is what I'm going to be talking about quickly. Making the diagnosis of endocarditis, the organisms that are involved, the treatment, and the indications for surgery. This is what we're going to cover in this brief talk. So, when do you suspect endocarditis? This is not an uncommon infection we see in the hospital, and we could see it in the community. What you have are the modified Goo criteria. So you have major criteria and minor criteria. There are two major criteria and there are 5 minor criteria. To diagnose endocarditis, you need 2 major, 1 major, and 3 minor, or 5 minor criteria. So the 2 major criteria, they're positive blood cultures, usually 4 out over 4 in 2 separate culture piles. Obviously, you're going to look for appropriate organisms, and abnormal echocardiogram consistent with endocarditis, an oscillating mass. To have endocarditis, basically, there are 3 processes. You need a source of bacteremia, fibrin plateletinitis, and an abnormal valve. These are the 3 things that make it work. And these patients develop endocarditis with the exception of IV drug addicts, usually have abnormal heart valves to begin with. The minor criteria. Number 1, fever. Number 2, you have positive blood cultures, but they're not at the level. They don't meet the criteria for a major criteria, but you still have positive blood cultures. Number 3, you have a history of an abnormal valve or an IV drug addict. Number 4, immunologic phenomenon. So immunologic phenomenon would include Osler's nodes, painful lesions at the tip of the fingers, rough spots in the eyes, glomerular nephritis, splenomegaly. You can see petechiae, okay? And the bugaboo petechiae are above the clavicle in endocarditis, okay? And then you can see vascular phenomenon, direct emboli, which an example, it could embolize really to any organ, but you think of the skin, the palms, Janeway lesions, or emboli to the brain, or you could have mycotic aneurysms. So these are the 5 minor criteria. And this is how you make the diagnosis, okay? Let's talk about the players, the organisms that you think of. So when you're thinking of endocarditis and what organisms cause this, you have Viridin strep, Staph aureus, Enterococcus, and these are the big 3. Then what? That's not the and then you have other organisms that you can think of: Haysack, fungal, Legionella, Bartonella, Coxiella. I'm not going to go into that, but really the big group are Viridin strep, staph, and endocarditis. So Viridin strep, here you have strep mutans, strep mutus, strep sanguis, strep intermedius. This is usually a more indolent infection. It could follow a dental procedure. These are usually group A strep. And historically, they're the most common organism. Staph aureus may have superseded them. Staph aureus, you could see that with any type of staph infection, and an IV drug addict with endocarditis, this is what you have to think of. It could often involve the tricuspid valve, and these patients may not have any pre-existing valvular heart disease, and they could be younger patients. And then there's Enterococcus. Enterococcus is not an uncommon cause of endocarditis, and sometimes it can be difficult to treat because of a lot of resistance. And Enterococcus could come from the GI or the GU tract. Under a subset of Staph aureus, there's a subset of these patients who are going to have methicillin-resistant Staph aureus. The HASAC group, Haemophilus acinetobacter, Cardiobacter, Euthenella, and Klebsiella, these people, they could be slow growers. They might not grow out right away, and it could take a number of days, and they could initially be put in the culture-negative endocarditis group. So let's go over quickly how we're going to treat these people. You know, initially, if somebody's at risk for Staph aureus, you're going to treat for the most serious cause. You're going to treat for staph. And then you could de-escalate. And if they're not at risk for Staph aureus, you'll treat for Enterococcus. But let's go over the basic players. Viridin strep, through the years, it's been treated with ampicillin and gentamicin, and they had different regimens, a 4-week and a 2-week regimen. Now it's treated with ceftriaxone, which is given once a day, an IV third-generation cephalosporin. Staph initially, until you get sensitivities, you're going to cover for MRSA, and you're going to use vancomycin plus rifampin. Rifampin will get into the prostatic valve if you have a prostatic valve, and if you're thinking about that. And there's some evidence that Gen should be added also to prevent rifampin resistance. Now, if the patient grows out MSSA, which is often the case, then you could de-escalate and you could go to either nafcillin or cefazolin. They have a prostatic valve, then you're going to use rifampin and probably Gen. And it would really depend on the patient, on what the patient has. Now, Enterococcus has also evolved. And Enterococcus, classically, this organism was resistant to cephalosporins. And however, there's been a change. There's been a change in the treatment over the last 10 years. And high-dose beta-lactam, like penicillin, along with high-dose cephalosporin, that's what's used together. They work together to treat enterococcal endocarditis. Now, if somebody has MRSA, okay, and for whatever reason you can't use vancomycin, other options include daptomycin, and there's a newer cephalosporin called ceftaroline, which could also be used to treat MRSA endocarditis. Okay, now when do you do surgery? Okay, number one, hemodynamic instability. So if somebody has severe endocarditis and they either develop severe mitral regurgitation or aortic regurgitation, they may need surgery. You're going to try and medically stabilize them first. Number two, lack of efficient therapy. The organism grows out, it's resistant to everything. Number three, failure of therapy. You cannot sterilize the blood. Then you may have to think of surgery. Number four, purulent pericarditis. Number five, possible valve ring abscess. Number six, conduction block, shows that the abscess is spreading and hitting the conduction system. Multiple emboli, not one emboli, but multiple emboli, and the antibiotics are not preventing that, and sometimes fungal endocarditis. These are the things that you're going to think about. Now, treating endocarditis, with Enterococcus, you could get resistance, and sometimes you have to use other drugs, like Zyvox, whatever. Sometimes it's resistant to other things. So obviously, you have to get the right sensitivity. So this is a brief talk on endocarditis. Basically, what I went over is how to make the diagnosis with the modified Jones criteria. A lot of interesting phenomena we often don't see, but they're fun to learn about, like Osler's nodes, Janeway lesions, and Ross spots. knowing the proper organisms that cause endocarditis, what scenarios we see them in. It should be noted there's one other cause of endocarditis I didn't mention. Another strep. It used to be called strep bovis. Now it's called strep galolyticus. And if this grows out in the blood and you have endocarditis, you have to evaluate the GI tract as an association with colon cancer, as does enterococcus. So if a patient develops enterococcus endocarditis, they're going to need their GI tract, especially colon, evaluated also. And with that, I'm going to stop. We're in the trenches. Bye.